Okay, the King Airway. This is referred to as a supraglottic airway device, technically classified as an oropharyngeal airway, kind of a special cuffed oropharyngeal airway. This is a little bit nicer and more user-friendly device than what preceded it, which was the combi tube, which was a little bit intimidating. This is not nearly as intimidating, and it works usually just about as well. So, the definition: the King Airway, King is the name brand of it, is an airway for single use for airway management. Most airway devices in these days, with the exception of a couple of things called laryngoscopes and a few tools that are associated, are single use. So just about every tube anymore gets thrown away as soon as it's done. It can be used by EMTs, AEMTs, and paramedics in our pre-hospital setting, obviously, who have been trained appropriately on this device. Sometimes the oropharyngeal airway or the nasopharyngeal airway is just not enough to help us maintain a nice airway. One of the big problems with either of those two devices is the fact that if the patient would vomit, that vomit can very easily be aspirated or sucked into the airway. When we put this device in, it has two inflatable cuffs that kind of isolate the airway. So to kind of describe it, we have a cuff blocking everything going down and a cuff blocking everything going up, and air comes out between the cuffs, and then that air is forced by proxy into the airway, into the lower airway. So it kind of takes the secretion and vomitus out of the game, at least temporarily. And we'll look at this device here in just a second. So with these two cuffs, we have a distal cuff, or also called the esophageal cuff, and it seals the esophagus. So it goes basically a little bit beyond the glottic opening, down the esophagus, and blocks it. The proximal or the pharyngeal cuff is designed to seal the oral pharynx, or basically right at the back of the patient's mouth. It will seal up that general vicinity. So leaving you basically just the pharynx, the general pharynx, or the laryngopharynx available. The proximal end of the tube, or the end of the tube that remains out of the patient, has a 15mm connector that can be used with your bag valve device, and the bag valve device is obviously one that we use to ventilate a majority of our patients. So to look at this device a little bit more, we've got the esophageal cuff, or also called the distal cuff, the oropharyngeal cuff, or the proximal cuff, and then there is the pilot balloon and the valve, and that valve is where we're going to inflate some air, push some air in through to inflate those two cuffs. The pilot balloon, which is attached to that, if it has air in it and is poofy, that lets you know that there's air in the cuffs down below. If it's basically sucked flat, that means that the cuffs down below are also flat or empty of any air. There's a colored tip, the colored colored proximal tip, which is where that connector is. That you can see the red tip on this one, and that's what connects into the bag valve mask. This version of the device is actually the LTSD. The S stands for suction, and you can feed. They have, if you look down through, look at the middle picture on the right side of this. It shows the gastric tube lumen. They've run just a little blue bar. It's actually called a bougie. Run a little bougie down through that suction lumen, which is right under the red cap there, and it comes out the other end of the device. And that allows for you to run a flexible suction tip down there and suction the gut if it would be needed. The one below that, the small one below there, talks about the ramp for passage of tube exchangers or fiber optics. That would be something that would be done in the hospital if they decide they need to change this airway for a different one. So it's not important for you as a field provider. What really makes the whole thing work, though, is the bottom left picture there, where it shows that there are the ventilation holes. So when we hook a bag to that red tip, we squeeze the bag, air is forced down that tube, and it comes out where those ventilation holes are. What you don't see here is that there's actually two separate lumens or holes that run down the inside of this device. And one of those is for the suction device that goes out the tip, but the other one is the main ventilation hole. So the suction one is relatively small, whereas the ventilation one is fairly good size and allows you to ventilate them rather easily. Most of the time you will get this in a kit, whether it's wrapped in cellophane or in a little plastic box. There's a couple different ways it comes. You can get just the airway by itself, but most companies or most services will get it in the package ready to go, and with all the supplies. And it comes with, obviously, the airway itself. It comes with a little bit of lubricant there, surgical lubricant. You usually will put a little bit on the tip there just to make it slide a little easier as you advance it in your airway. And then it usually comes with a syringe as well for you to inflate those cuffs. Now, you usually won't have the cuffs. The cuffs won't be inflated as it shows in the picture here when you get it out of the package, but it's just for demonstrative sake. This device, you can kind of see, if you look real closely at it, you can kind of see where the air holes are and how it's going to come out in between the cuffs there. And you can look real close. You'll see that on the upper edge of this picture, or the back side of the airway itself, you can kind of see where the lumen are separated there, and there's that little smaller lumen that will allow you to poke a suction catheter out the tip, as opposed to the larger lumen where you ventilate. So the indications: this is to promote airway management by providing a patent airway. Note that that's not patient, that is patent. Patent means good and secure. A patent airway in the unconscious apneic patient. Apneic meaning no breathing. So, and the King is also a latex-free product, so that's a nice thing. We see a lot more latex allergies popping up from time to time, so it's nice that it is latex-free. So this is going to give us a nice secured airway. The contraindications is responsive patient with an intact gag reflex. If they're sitting up looking at you and talking to you, they don't need a King. If they have some known esophageal problems, such as esophageal varices, which is essentially, to be very blunt about it, esophageal varices are very swollen blood vessels, essentially like hemorrhoids or varicose veins in your throat. Cancer, certain cancers that develop tumors and whatnot, and certain types of tears or trauma to your throat, particularly people who throw up a lot, whether that's an eating disorder or they're alcoholics or what have you. People who throw up a lot will have certain types of tears develop in their esophagus that will potentially burst. Many of these times, if you show up this patient as completely unconscious, nobody knows any history, you're not going to know, you're going to use it. So, and finally, patients that have known or suspected to have ingested a caustic substance such as an acid or an alkaline, bleach, ammonias, the things like hydrochloric acid, battery acid, so on and so forth, because they'll be trapped in the throat and cause more damage. There is occasional adverse effect that you'll see, or kind of what we sometimes refer to as side effects, may cause the patient to vomit and aspirate if you don't get the airway in quickly and correctly. Can cause some excessive pressure in the abdomen if for some reason ventilation was not successful right off the bat, the airway was placed incorrectly. And bradycardia. Sometimes when we feed that airway down their throat, it stimulates the vagus nerve, and that vagus nerve causes their heart rate to slow down. Some additional equipment that you will need beyond just your airway. This is usually something that you're not going to take 10 seconds from start to finish. It's going to be a couple minutes of planning and doing. So things you're going to need a stethoscope so you can listen to their lungs and their gut after you're done. A suction device just in case they vomit. Universal precautions. You should preferably protect your face, both your eyes and your mouth and nose, and your hands. If you've got gowns, great, not necessary, but it's just an extra precaution. You definitely can do this with no less than gloves and some sort of face protection. So, an oral or a nasal airway. So when you start ventilating this patient to hyperoxygenate this person before we put the airway in, we want to have some sort of airway. And we don't always go to the big guns right away. So if we can start with a basic airway, if we determine that's not working, then we can step up to the King Airway. The oxygen source, an oxygen bottle, obviously to work with our bag valve mask so we can provide the patient high flow oxygen. The bag valve mask device, you will need the whole device to start with, and when you are, after you've placed the airway, you will no longer need the mask portion of the device. And then some sort of a tape tube holder or something along those lines that will hold this tube in place so it doesn't go anywhere. So instructions for use. You're going to choose this appropriate size airway based on the patient's height. There are actually 5 different sizes of King Airways right now. There are a few more considered, but right now there's 5 sizes that are available. You're going to test the cuffs by inflating them to the recommended volume of air and deflate the cuffs completely before attempting to insert. There's a little card that will come with, or there'll be printed instructions on the package of how much air to put in the cuff and what size patient it is to be used on. You can generously lubricate the tube using some water-based lubricant. Water works just fine for this. Pre-oxygenate the patient with 100% oxygen. So we're going to take and ventilate our patient. We've got our oral or our nasal airway in. We're going to ventilate them at a normal rate with our high flow O2 to make sure we kind of stack the deck with some oxygen before we take away their breathing for a little bit to put this airway in. We also are going to have our suction sitting right there available, standing by in case the patient would vomit. So we're going to determine what size we're going to use by the patient's height. The typical adult sizes are the yellow, red, and purple ones. Yellow is 4 to 5 feet, red is 5 to 6 feet, purple is over 6 feet. The simple majority of people are going to fall usually in the red category. But it's probably a good idea to have at least one of each of these sizes on your truck. And just for a source of reference here, if you look at the airways pictured here, these are not the S version. You cannot suction down these. So if you look at the tip of it, there's no hole in the tip of it. It's just a rounded tip on there, and there's no port on the back side for you to run that suction catheter down. The 2 not pictured are the pediatric sizes. These are still very early in their use. Not a lot of places have picked up and are using these yet. I would expect that eventually they'll become a little bit more mainstream. But the green pediatric size is for 35 to 45 inch, and the orange is for 41 to 51 inches. So there's a little bit of overlap in size there, as well as the orange slightly overlaps the yellow because of yellow would be 48 to 60 inches. So there's a little bit of overlap there. So that's the sizes. And again, like I said, this should be listed on the package usually. Here's just a little reference chart here. The patient's height in inches and feet, the color of the device or the connector, and then the cuff inflation volume. How much air should we put into that cuff when we inflate it with the syringe? It's probably best to go about mid-range. If you have a particularly, maybe you have somebody that's on the tall end of the size, so they're on the top side, maybe you go with a little bit more air, versus somebody who is on the bottom side of this. You might go with the closer to the bottom end of the range, but in general, go about mid-range. You can always add a little bit more air, or you can take a little bit of air out. You're not going to know if you need to take the air out, but you will know when you need to add air because you'll hear air squeaking by when you bag the patient. Just as a note there for the adult size devices, there lists the King LTD and the King LTSD. Just so you're familiar, King laryngeal tube disposable or King laryngeal tube suction disposable, and that's what those stand for. The ones that have the suction port in the back generally need just a little bit less air in the cuff because the tube itself is a little bit bigger around. So that's why it doesn't need quite as much air for the suction version. So insertion, you position the patient head slightly sniffing position. There's going to be a video in your course page that you can watch that for the most part is pretty spot on for what we're talking about here as well. There will be regional variations of how things get done a little bit, and that's okay, just as long as the main concepts are kept at the core of it. So unless there's a known spinal injury. If there's a known spinal injury, you need to keep maintaining cervical spine immobilization or restriction and keep their head in a neutral position. But that sniffing position is just with their nose just slightly turned up a little bit. Insert the King Airway rotated about 45 to 90 degrees laterally, so almost tipped over on its side in your hand. So instead of your thumb being straight up in the air, your thumb's actually pointed out to the side as you're holding the airway. And then insert the airway into their mouth. As you get into the mouth, then you can slowly rotate the tube back up to midline or thumbs up, and advance the tube until the base of the color connector aligns with the teeth or the gums. So I've kind of got some pictures here now to show you. So they show you that you kind of have your airway rotated out. They're doing a tongue jaw lift there to hold the mouth open. And then you're going to use this lateral approach and introduce that tip to the mouth. Advance the tip beyond the base of the tongue while rotating the tube back to the midline, so the blue orientation line if you care, faces the chin of the patient. So you see they've gone from side all the way back up to upright. Advance until the color connector is aligned with the teeth of the gums. And then you're going to inflate. So you're going to take your syringe, you're going to put the appropriate amount of airway in, or air in there, so with the minimum volume necessary to seal the airway according to the tube size. Now, like I said, you may need to vary this depending on the size of your patient. You can always go back and put in a little bit more air if need be. When you are done putting air in, take the syringe off. Really the way that whole system works with the air cuff in there is just like your tire valves on your vehicle. If you press down the little stem, you can see it in there white. You press down that little stem, which the tip of the syringe does, it opens the valve and allows air to go in and out. Once you pull the syringe off of there, the spring-loaded little white pin pops up, blocks any air from leaking. So remove the syringe. Okay, attach your bag valve device to the King Airway, and then while you're bagging the patient, just very gently pull upward on that device just a little bit. You just pull up very gently on it. Generally, you'll feel a difference in the way that you can bag, and the ventilation will become a little bit easier, and then you're in the right position. Kind of note where that airway is at. You're going to assure that the chest rises and falls well. Listen to the breath sounds. So listen, I usually tell people to listen somewhere above the nipples, and then listen to the pit of the gut where about your stomach is. Don't listen real low on the lungs initially, because you may confuse sounds of the gut for sounds of lung sounds. So if you hear air going into the stomach, you'll hear a gurgling sound. Secure the tube using either a commercially approved device or tape, and then note the depth of tube placement if you can. There's usually some little markings on there. Monitor the patient for improvement. Usually you will see some vital sign improvement unless they're in cardiac arrest. Skin conditions will usually look a little bit better. They may not be quite as blue or as pale. They might stop sweating. So monitor for improvement. This just shows you kind of how is it supposed to sit in there and where does everything sit and fit. And like I said, it's got that proximal cuff kind of blocking the back of the mouth, and it kind of invariably will block the nasopharynx as well. The esophageal cuff or the distal cuff blocks off the esophagus. Air can only come out between them through the ventilatory openings, and it gets pushed down into the trachea. That's kind of how that works. Remember that you're going to have to document this. Who did it? When did you do it? The size, any patient's response to the procedure, any complications also would be important to put in there as well. When you're placing the King Airway, we're hoping to not have to interrupt CPR and or ventilation for very long to do this. So that means be ready. Be familiar with the device, have everything laid out ready to go before you decide to do this, because once you take the ventilation bag away from the patient's face, they cannot breathe. And your cohorts may want to stop CPR to do this. It shouldn't be necessary to do that, but if necessary, tell them to stop for half a second, slide that baby in there, tell them to go ahead and continue. And then if you need them to stop for a split second so you can listen, that's fine too. But in theory, there should really not have to be much, if any, interruption. And then if the spinal injury is suspected, make sure we keep them in proper alignment and do a proper immobilization job to go along with that. And in fact, this device will help us ventilate those patients much better because we don't have to worry as much about jaw thrusts. If for some reason we would need to remove the device, such as the patient starts to wake up, you need to have a couple things in mind. Prepare your suction. They will vomit. Almost guarantee it. They will vomit. Cut the inflation line below the pilot balloon and the inflation port. Some people will say just suck it out with your syringe. Well, you're not going to reuse this device. It's a one-time use only. Cut that pilot balloon off of there. You don't have to worry about it being in place. You don't have to dink around with the syringe. You just cut it off there and the air will escape naturally. Pull the device out, have your suction ready to go, and then if they either after they've done vomiting and you're done suctioning, or if they don't vomit, we'll probably place that patient on a non-rebreather, high flow oxygen, because they have undergone a fairly significant condition, and so it would be appropriate to make sure that they're still getting a nice supply of oxygen.